Well, for the new patient that's coming through, they've gone on the creams, and that's a whole nother technique of making sure, like you said, shaving the scrotum, leaving enough time for it to dry. Not every man wants to do that.
I'm not doing any cardio. I get out of breath when I go up the stairs. Maybe the solution is to be able to tolerate the healthy dose that we want to give them. If we've got a scenario with cream going, okay, well, if we put it on twice a day, then we've got the benefit of levels being more stable around the clock. Now we're replicating the body's natural rhythm more. Now we're not having to worry about intimacy in the evening. Pro, you only have to do it half the amount of times. That's cool.
One of the things I wanted to address is a lot of people will say with this difference why they feel more inclined to want to do subcutaneous injections is because of the perceived scar tissue. Now, I spoke with a doctor from the States, Kathy O'Neill Smith, who made a good point, and I've seen this in other studies, that your muscle's more vascular, your subcutaneous area isn't, and diabetics who do insulin we're talking a water-based hormone, are still getting scar tissue. It's subcutaneous with a water base. So you can only imagine what the oil, and hence why we probably see some of the deposits and lumps and bumps from doing subcutaneous. I can't say I've never seen scar tissue in the muscle, but you would think that the scar tissue is going to heal more because it's more vascular, it's more blood flow. Just because you're doing it there doesn't guarantee you're going to have some scar tissue. And is a scar tissue going to be debilitating? It's probably going to heal.
You've been doing this for probably longer than most people. I was going to say,
I don't have scar tissue on my bum, or nothing that's caused me to have a limp that I'm aware of.
I think one thing that comes up a lot, and like when I say this, I'm not shitting on guys who bring this up. It's just that it's a very common thing that comes up for good reason, because this is all new territory. Is that what happens is they're using their delt to do their injections, and they're putting the injection in here. And then 3 days later, they're putting the injection in here, and then in here, and in here. They're putting it in the same, 0.5 centimeter squared region, and there's still oil dispersing in that region. So they're going, oh, I've got scar tissue after being on this for 2 months. No, you've just got oil dispersing in the area, which when you're putting the needle in, you can feel that. And that's why it's important to either use the whole muscle belly that you can, or rotate injection sites, or use, if you're using the glute, you've got a much larger area to do. But don't pinpoint the exact same spot every single time. That's not scar tissue. But I mean, I was doing daily shallow intramuscular injections for 3 years into my delt, so every day alternating. I have zero scar tissue, zero problems.
So I guess that's one of the internet myths out there for that. So all right, so for the new patient that's coming through, they get on their injections, they feel comfortable doing the injections, they've picked either, traditional intramuscular or shallow intramuscular, or they've gone on the creams, and that's a whole nother technique of making sure, like you said, shaving the scrotum, leaving enough time for it to dry. Not every man wants to do that.
I think that it's intimacy is the way that it's going to transfer. I mean, unless you're going around rubbing your scrotum on people, which generally people don't like when you do that.
You just put it on the back of the scrotum instead of the front of the scrotum.
You put it on the gooch. It's a good spot. I think the reason why it can be an issue for guys to do it twice a day is sleeping naked with their partner. And I think if that's going to get in the way of the romantic bond and the intimacy, and if it's going to take the spontaneity out of intimacy, I think that's something that's going, this is now a bit of an inconvenience to something that is special and important. But do it once a day. And I think that, is it more optimal to do it twice a day? Absolutely. But there's also guys who don't sleep as well putting the cream on before they go to bed.
So we've seen patients like this. They can't sleep. It keeps them awake. Anxious.
So if we've got a scenario with cream going, okay, well, if we put it on twice a day, then we've got the benefit of levels being more stable around the clock. Great. Pro. And then you've got cons. And some guys sleep better when they put the cream on before bed. So it's not like everyone's going to get screwed up sleep. But then you've also got this other category of going, well, okay, well, what are the pros of doing it once a day? Now we're replicating the body's natural rhythm more. Okay, pro. Now we're not having to worry about intimacy in the evening. Pro. You only have to do it half the amount of times. That's cool. I guess small pro. But now you're in a situation being like, well, now I'm getting a bigger peak and a bigger trough. So that's a con. But I think that they both kind of level out, and you can pick whichever one works for you.
I think the peak would probably come a bit later than your own natural production would, unless you wake up so early.
Yep.
You know, if you're waking up 7 or 8, I mean, that peak may have come at, 5 or 6.
Yep.
You know, and then obviously cortisol's peaking as well. But I mean, it's close enough.
Close.
But then, are you going to be feeling like you're left too low in the evening? So
yeah, case by case. And some guys will metabolize it faster, some guys metabolize it slower. I personally recommend that guys do it twice a day.
Yeah, that's what we know.
Absolutely. I do it once a day because I have found that my levels, I must metabolize it quite slowly. So I don't have any issues doing that. I'd rather be in a more convenient standpoint. But from a recommendation standpoint, as someone who coaches people in this, twice a day I think is objectively far more optimal. But if you're like, I can't do it twice a day, cool. And this is what my friend Dr. Keith Nichols says as well. Twice a day is best, but if you can't do it twice a day, do it once a day.
And a lot of people want to know, like they've asked me on some of the questions on YouTube or the comments, what do I do and what are my levels? And I know you talked about you do the cream, I do the injections. On the trough, I'll say that my levels on 50 milligrams every 3 days, the trough is around 32 nanomolars per liter.
Right. Yeah. So you're more sensitive to it than the average guy. Most guys wouldn't have a level that high on that kind of dose.
So I've had anywhere from 29 to 32. That's usually before the next injection.
Sure.
And I feel fine. I feel really good. I feel healthy. I've had it a little bit lower as well, 20, 25.
Yep.
So it's kind of all. And again, there can be variation in blood tests when you do it.
Yep.
On creams, I've had it when I've done the cream in the past years ago. I've had it, and it's a good example that you mentioned where I think I left it for nearly 24 hours. I left a really long time before my next application, but tested it, and I think it was probably, just trying to convert it to nanomolars because at the time it was in nanograms.
Yep.
I think it was closer to 15 nanomolars per liter, or around that level, 400 nanograms, and I felt fine.
Yep.
Because you said and we tell our patients, don't worry if it's just a couple of days out because your receptors are still being agonized, or you still the receptors are still full of testosterone.
Yep.
Anyway, what's yours?
I was a little bit of a lower responder to injections than the average guy. So I was using 250 milligrams a week of injections, and this was getting my total to anywhere between 40 and 50, depending on the day. But I had a bit of a higher SHBG as well, so I was optimizing my free. Now, I'm in the category of guys who I don't get symptomatic resolution of my low testosterone symptoms unless I am in the higher end of what we would consider TRT for free testosterone. When it comes to cream, it was actually very easy for me. I went to 200 milligrams a day of cream, so half a mil in the morning, half a mil at night, and then I just went to 1 mil in the morning, and that got me to a peak of about 50, 55 total, and then it got me to a trough of about 20 to 25, 24 hours later. So it was quite transferable for me in terms of just swapping over. I had a very easy, I didn't really notice much subjective difference. Maybe I slept a bit better, but yeah, it was very easy for me. But for me, I find that there is, and when I talk about the units we use in Australia and what you guys use in the UK, it's just a decimal place shift for free.
You don't use nanomolar
or for free.
For free.
Yeah, so
are you talking about the free assay, or are you talking about the
calculated free?
Calculated.
Yeah.
That's a whole nother area, because we prefer the calculated free because it's more uniform across the board. SHBG, albumin in total.
Yeah.
The assays could vary depending on the machine they use for the assay.
Yeah, they're useless. Yeah, and it will come in just whatever. Plus, when you're working with guys all over the world, which drives me ballistic in Europe, sometimes they'll put the wrong units. And so you've just got to calculate it anyway.
One of our case managers called me this morning, actually on a Sunday, and she had this case where someone gave them this weird units, and we had to convert from picomolar to nanomolar.
You got to do it 3 times. Yeah,
we had to do it 3 times, a different conversion.
Yeah, you just got to work out the total and calculate it. But yeah, when it comes to the free, I find that guys, and it depends on the guy, some guys will do well at 0.5, 0.6 free. Some guys need to go all the way up to 1.5. Or in Australia, and in my book that I wrote, 600 to 1500. Same, just decimal place moved across. And there are varying factors that I think contribute to that. I think genetic androgen receptor availability is probably the biggest one.
CAG repeats is one, but it's so difficult to get those tested properly. And even when you get like the Nebula Health, where you keep your data, it's really hard to find the SNPs where you can say, is that a long CAG repeat or short CAG repeat? And it'd be amazing if we can come up with a software that would do that. But because that also would help you bear in mind someone who is complaining of symptoms but don't always match the exact reference ranges. You would have evidence to say, well, maybe they were always higher. The CAG repeats show that they require more testosterone than everyone else. Therefore, we need to look at a different set of range for them. Or on treatment, they may require more testosterone. But there are other ways to do the same thing based on symptoms, based on how they feel, based on other parameters. Some guys you can have almost super physiological levels for years and you never see an increase in hematocrit or hemoglobin.
Yep, that's like me. Yep.
And other people just ever so slightly high and you can see an increase. Now, to be fair, I don't know if everyone knows, but hematocrit's a calculation.
Yep.
I think it's the mean cell volume times the red cell count.
Yep.
I think divided by 100 gives you the hematocrit number. So I had an incident, and this can happen also. Guys have to be aware of this. If the lab holds on to your bloods too long, and the swells, or if you think you're going to be cheeky and really change that formulation and just drink loads of water, an hour or two before the test, you can cause the red cells to swell, and you have a larger mean cell volume, and it goes in the calculation. You think you've got this massive hematocrit, so both can cause that. But I know there's been that's a concern of a lot of people, is what's going to happen to their red blood cell hematocrit hemoglobin on treatment, and how dangerous is that for their heart health. And I think there's different sides in the TRT world who some will say, no, we have to phlebotomize, we have to get everything into order, or lower the dose, or a combination of both, maybe baby aspirin. And others will say, no. I think like Dr. Rouzier did a presentation saying that only the data that's like that is for kidney patients who have kidney failure, but everyone else, it doesn't seem to be an issue. What have you seen?
I think this is a great topic because there are people who I love and respect who disagree. And this is what I like, because there's nuance, and I think there's multiple ways to skin a cat, and I think that there is different ways of looking at this, and I think that it's going to come down to a variety of factors for the individual. But I tend to kind of sit more on the side of conservatism with most things. I think it's better to be safe than sorry, particularly when we're making interventions in people's health. But I look at things quite holistically as well. So you've got one side. Firstly, when I look at it, is that you could have polycythemia from being obese, sleep apnea, alcoholic, poor cardiovascular fitness, and you can have someone who's very healthy and lean, who's had their red blood cells increase from androgen therapy, and they will both reach the same hematocrit number. That is two completely different scenarios in terms of what we're looking at, which at the end of the day, I would assume is going to be all-cause mortality. You don't want to die. So the difficulty when we're looking at this is, one is increasing in the context of someone being very unhealthy. The other one is increasing in the context of increasing red blood cells to be able to increase oxygen capability of the body, to be able to basically use more oxygen, which is part of the therapy of what we're trying to achieve with testosterone. I sit in the middle because I go, well, if you do this on top of this, then now the blood's going to be like fucking goo. That's how I look at it. So I think that we're in a scenario going, and this is kind of going back to what I spoke about before and at the Silverback Summit, is that if you take the healthy levels of a 21-year-old and put them into an unhealthy 50-year-old, if you put a sports car engine into a Suzuki Swift, it's going to blow up, it's going to fall apart. You might feel great ripping out of the car park, you might feel like King Kong, but if your hematocrit goes up to 60, 65, your heart's going to be working really
hard.
So I think it's a tricky situation when we're going, okay, well, idealistically, they're not going to have sleep apnea. They're going to be lean. They're going to be doing cardio. But what about when they're not? What do we actually do? And our mutual friend, Dr. Rudy, he made a video the other day on this saying that he was, a proponent of phlebotomizing here. I think that if you've got someone who's coming into you, and again, I'm not a doctor, but I imagine if I was a doctor, if I'm in a situation where someone's a metabolic emergency, I have a duty of care, and I genuinely don't want to see harm come to the individual, might be going, okay, maybe a phlebotomy is a good route here, especially because getting to the point that you don't need a phlebotomy might take some time. And I think that that's where and this is what Dr. Rudy spoke about before, is going, we're not just looking at the number on paper that once you get up to whatever number I decide, then blood lead.
Right.
But we're going, okay, well, what are your symptoms? So if someone's got a hematocrit hemoglobin of 55, 56, blood pressure's low, they're feeling great, no issues, versus if someone's got a hematocrit of 53 and they look like a turnip, then that's going to be a different scenario. But I think the nuance here is that there is no circumstance in which an unfit, sleep apneic, obese guy who never does cardio is going to have a total testosterone of 40. So I think now we're going, okay, we're creating an unnatural situation here. Has this been studied? Has this specific thing been studied? No, we're extrapolating from different circumstances that don't apply. So I think there can be, if someone is in a situation where they need a phlebotomy, ideally we want to get them to the point they don't need that. Healthy men do not have to bleed regularly. It's not part of that.
Though there was an Australian study about the forever chemicals, and frequent phlebotomies can help remove the forever chemicals from the blood. So it might not all be bad. There may be a therapeutic reason for doing it. I think that the negative of the therapeutic phlebotomies are, you get this rebound effect. You can take too much out in one go, or in a too close a time. So preventing it is better. So if you did, we've always said, it just as a nice thing to do is donate blood, because you've got plenty of red blood cells, especially if you're on treatment, and just do it at the normal time intervals that the blood donation services like to take it. I think even win a dinner at the end of the year if you go through all the different times that you're supposed to donate. Then I think that's okay. There's nothing wrong with that, and people can use it for the blood supply. Unfortunately, sometimes when you're on TRT, the blood supply, people don't want to take it. Because you'll get this misdiagnosis of polycythemia vera, which is completely different. And I still agree with Ruzi about erythrocytosis, but sometimes they get used synonymously. And I think the other point is there's certain guidelines that have been set up. I think the European guidance is over 54%. And have kind of some sort of intervention, either stopping treatment for a short period of time, lowering the dose, increasing the frequency between injections is another area. I think a third thing we've noticed, and there's some studies that show that the free testosterone level, how high it is the greatest predictor of this increase in red blood cells. So if you can kind of manage that, you may be able to prevent it. So sometimes lengthening, I know this is counterintuitive to the microdosing philosophy, is sometimes increasing the length of time between injections gives it enough time to clear. So now you've got a lower trough level. And that's sometimes more suitable than stopping therapy altogether for some patients. And then I've also seen the guidance talk about sometimes the baby aspirin in those cases to hopefully thin the blood. One thing that I'd used in the past is pentoxifylline, which is almost a generic PD inhibitor. I think it has PD5, PD4. It helps the blood flow more easily. It has some anti-inflammatory effects. It lowers TNF-alpha, TGF-beta1. Quite helpful, but it's not really a new drug and not sexy. And a lot of people don't know about it, even though I think the BMJ had written an article about its usefulness in heart disease. So there's lots of different things people can do. I guess, like I said, there's more the way to skin a cat. But sometimes it's one of those things people get very, very worried, especially when it comes to blood viscosity, their health. And I think the best approach is, like I said, being a bit more conservative with what you're doing.
And I think that the important caveat for it is that people don't band-aid the underlying metabolic issue that's causing the problem in the first place. And if we're in a situation being like, okay, go get phlebotomized at X interval, that's a band-aid, not a solution. And what we wouldn't want to do is be doing that to prevent someone from getting a sleep study or increasing their cardiovascular fitness and all these kind of things, which I think is, and that's, again, coming back to the importance of the health coaching and working with them from an educational model.
So what is it about cardio? And I was going to say, that's a very good point, that usually that was a red flag for us when we get a patient that comes back with an elevated hematocrit hemoglobin. What you also need to investigate whether it is a sleep apnea that's causing it, or if they're a smoker. There's something blocking their oxygen. And now even, and something that I've noticed, and I think a lot of people don't talk about, especially the biohackers who take all the supplements and the vitamins, NAC. In some people, if you're taking it every single day, I think it shows up to an 8% increase in hematocrit and hemoglobin. So. And, I said that happened to me, and, I would have rather been on a massive dose of testosterone to have that effect rather than taking it from a supplement called NAC. So I guess barring that, with hematocrit hemoglobin, and what final thoughts do you have on it?
As I said before, the human is an interconnected series of systems, and the red blood cells are basically the fuel that is flowing through your body at all times. So everything is going to influence this to some degree. I think that it's very important that people look at if there's something going on in their health that's wrong, that's not something like genetic hemochromatosis or something like this, that they're going, what am I doing that I shouldn't be doing? And what am I not doing that I should be doing? Because just because you don't understand how that's connected to this doesn't mean it's not. So I think the best thing that people can do is go, if there's a concern with their health, not to reach for immediately reaching for phlebotomy, medication, whatever, being like, what could be off? What could I not be doing right? And I think that sometimes it's a blaringly obvious thing that maybe they wanted just to get away with and they're not. So I think that that's an important thing to look at. And the other thing with I guess, and this would also tie into the blood pressure thing as well, is that you need to do cardio.
Yes, also
and my friend Jay Campbell is the biggest cardio proponent in the world, so I'll give him credit here because it's absolutely credit where credit's due, is that you have to do cardio is not just a tool for calories out. You can do cardio from doing supersets and giant sets or whatever, but you have to do some form of cardiovascular training to be able to actually support having high testosterone levels. And it's I think, and again, this is actually, I'm borrowing this from Jay, is that when you go on TRT, you are now having a higher requirement for doing more cardiovascular training. It's kind of like if you buy a Lamborghini, you need to learn how to drive better than if you have a Suzuki Swift, because you're going to spin around the corner and going to spin out and lose control. So I think that when it comes to the daily health habits that people are looking at, if you're on TRT and you've got a total testosterone, like you mentioned before, 30, and your blood pressure is 150/90, is the solution to drop the dose, or is it to get a treadmill? And if someone's going, well, I'm not doing any cardio, I get out of breath when I go up the stairs, maybe the solution is to be able to tolerate the healthy dose that we want to give them, rather than to back the dose off because they're not doing the things they know they should have been doing in the first place.
About cardio, that's what I was going to say before. I think there's a mechanism by when you do cardio, you do lose a bit of the red blood cells as you do them, which helps keep that number down a bit. I can't remember the name for it, hematuria, I can't think. So there is a certain benefit from just the movement and the exercise. You do lose some red blood cells that may be helpful.
Yeah,
and you're right. It's almost a therapy. I've always done a certain level of cardio. I was always doing the interval training, non-impact kind of the cross trainer, the elliptical.
Yeah, I like
that. And I have this thing where I'll do, like, the first 4 or 5 minutes is kind of warm up, bringing up the heart rate. I watch it on my watch, I tap it, it records it. Right. And then I eventually get my heart rate, so it's getting 100, 110. And then I do the intervals. And then I like to bring it up towards the end of it to about 140. For me, I'm going to be 50. That's pretty good. Yep. And maybe 150 at the most. And so I'm now at about 85% of my heart rate. And I'm trying to build up the VO2 max, which is another benefit. I think they say the better higher that your VO2 max is, the better longevity. But it's a bit of a scary thing to tell someone that if you've got a shit VO2 max, and there could be other reasons for it, that you're going to die soon in the next 10 years. I don't like the way that's been positioned in some cases. But anyway, for me, I've always believed that a bit of warm up, either cardio or press ups or something to start training with, get into some resistance training. And then I would normally finish it off with some cardio after about 20, 25 minutes. So I don't know, everyone's got their flavor, what they like, but for me, that's really worked. And getting that heart rate up is important too, but maybe not every time to the 80% max. Yeah.
I think that's really important, because one thing that people look at, again, because they're coming at it from a calories in, calories out standpoint, is steps are not cardio. Steps are movement. Steps are important. Movement is important, but you also have to actually train the cardiovascular system by getting the heart rate up and doing the thing that makes you sweat and gets you out of breath, gets you to the point that you couldn't maintain a casual conversation with the person next to you. Now, if you're obese and deconditioned and out of shape, maybe walking is that for you to begin with. But if you're at a point where you're wanting to optimize your health, you need to actually try it when you're doing your cardio. And whether that's, I don't care what people do, whatever you're going to do that. So, it can be a spin bike, you can be going for a ride, you can go for a run. I like the elliptical as well. I personally like to get like a good set of headphones, put on my favorite music and just zone out. And I find that, like, The first 10 to 15 minutes, I'm like, ugh. And then once the endorphins hit, you're like, yeah, I'm going, I'm good. Martial arts, you can do Tabatas. Like, I don't care what people do. Like, I often tell people,
What are Tabatas?
Tabatas is that like, it's like 12 seconds on, 8 seconds off, or 8 seconds on, 12 seconds off. It's like a series of 8 rounds that you do of like short bursts of exercise. And it was developed for increasing oxygen capacity for downhill skiers. So it's just like you can look up on your phone Tabata on Spotify. There's a whole bunch of playlists, and you can just do like, if I'm in like a hotel and I'm traveling, they don't have a gym, I just do rounds of Tabatas with like push-ups and squats and just, kind of do that on repeat. But there's so many ways you can do it. And one thing that I like to do is I'm a big proponent of martial arts as a form of therapy, and it's just a form of something that I think is beneficial that people do as a skill to practice, maybe not actually competing in it, but just actually having the experience. And one of the advantages of doing martial arts is if you're unfit, you're going to have a really bad time. So having something that holds you accountable weekly to maintaining a good level of cardio, I think is really beneficial. And for the guys who are like, they won't do it, they can't do it, they make up every excuse under the sun for not doing it. Facebook Market, spin bike, Facebook Market, Xbox. Put it in front of the Xbox, Netflix, play Halo and do your cardio, I don't care. But you've got to find a way that you can rig your environment in your favor to do the hard thing that you don't want to do.
If you found this video helpful, don't forget to watch our other videos on topics around HRT and TRT, and don't forget to subscribe to the channel. And until next time, stay in good health. This is Mike from Balance My Hormones.